But it's my pleasure to introduce our guest for today. I think most know that I'm on the board of directors of the American Board of Internal Medicine. And I think it's really important for us to hear from some of my colleagues about learning and how that sort of learning and exam performance and some of the pedagogy that's associated with formative versus summative and consequential sort of assessment and how that drives learning. And then also understanding what that really has to do, particularly in healthcare and health outcomes and patient outcomes. And so there's a lot of information that I didn't know existed at ABIM. And that's why I think as we're in this curriculum renewal process, it's great to have our two guests join us today to talk about this. And so I'll introduce them both. They'll both be speaking, but I'll introduce them and read their bios and then turn over. And I think Dr. Lipner is going to be the first one to start. So first, Dr. Lipner, who is the Senior Vice President of Assessment and Research at ABIM. She oversees a team of measurement, research design analysts, employing measurements to ensure high quality assessment program across the enterprise. She employs qualitative and quantitative methods and disseminates evidence-based research. And in her role, she ensures that ABIM products remain relevant to the practice of internal medicine and identifies new possibilities and innovation in assessment and technology that guide new initiatives. Dr. Lipner has focused on innovative methods in medical assessment, computer-based, high-fidelity simulation, has been a frequent speaker, and prior to joining ABIM, she was at teaching positions and faculty positions at Drexel, St. Joseph's, and the University of Pittsburgh. And then Dr. McDonald, Dr. Furman McDonald, just move this out of the way, is a Senior Vice President of Academic and Medical Affairs at American Board of Internal Medicine. He also is an adjunct professor of medicine at both Mayo Clinic College of Medicine and Science and Perelman School of Medicine at University of Pennsylvania. So Dr. McDonald is a board certified internist and provides physician leadership over the council and specialty boards at ABIM, graduate medical education related leadership. And in these roles, he supports development and implementation of policy and standards for the certification program. Prior to joining ABIM, Dr. McDonald was a program director of one of the largest internal medicine residency programs in the nation at Mayo Clinic at Rochester, and also was a member of the RRC for internal medicine. He's published many publications and really studying the link between GME and patient-relevant outcomes. Dr. McDonald remains clinically active as a supervising physician at Resident Continuity Clinic at Pennsylvania Hospital. So without further ado, I will give this to Dr. Lipner, who will start talking about the presentation. And feel free during the presentation to jot questions in the chat, and we should have an interactive time after the presentations are over.
Okay, can you all see that?
Yep, we can.
Thank you. Good evening, everyone. It really is my pleasure, and I'm assuming it's also Furman's pleasure, I'll speak for him right now, to talk with you today about connecting continuous physician assessment with quality patient care. And this is a perspective that we feel is very compelling. You may not, but bear with us and keep an open mind about what we're going to give you today as sort of background information about continuous physician assessment and why it is important to us, especially for maintaining high quality patient care. So both of us work at ABIM, American Board of Internal Medicine, and this is ABIM's mission statement to enhance the quality of healthcare by certifying internists and subspecialists who demonstrate the knowledge, skills, and attitudes essential for excellent patient care. And we are of the profession, but for the public. Here's my disclosure statement, and I won't read it out loud, but I'll let you have a few minutes to read it. Furman's is a little bit longer because he's a physician, so he has a little more conflict than I do in the space here. Okay, so what we're going to do today is really a two-parter. We're going to sort of tag team it. I'm going to do the first part of this, and then Furman will do the second part where he'll talk about sort of the more operational and practical implications. I will be talking about the more theoretical part. So the first part is really about synthesizing the results of hundreds of papers that have helped us define a theoretical framework for continuing assessment of a physician's clinical knowledge. And I'll explain a little bit about why we even did that. But that was an important part of moving into our longitudinal assessment program. Part two is taking studies and validating continuous assessment in terms of their associations with clinical outcomes and processes of patient care. And that's the part that Furman will be talking about today. And at the end of the session, you should be able to identify some optimal conditions for how testing itself or assessment can potentiate learning and retention, and describe how goals and consequences actually motivate learning and retention, and then better understand the evidence that we have behind why continuous assessment is important for patient care. So let me turn to the theoretical part of this talk. So basically what happened quite a number of years ago is that physicians started asking the ABMS community, the American Board of Medical Specialties, to provide an explanation for why do we need continuing certification? Like, why can't we just do CME, get our initial certification, do our continuing medical education, keep our license up to date? What's so important about continuing certification? And at the same time, many of the boards started thinking about different ways of testing. Instead of high stakes testing, more lower stakes testing for continuous certification and doing it more frequently. So trying to combine what we call the assessment for learning, the more learning aspect of things, with the assessment of learning. Did you actually learn anything, and how do I know that? So coming up with programs that combine those two. And so what we did at ABIM is try to get a better understanding of the foundational science underlying maintenance of medical expertise, or just clinical knowledge in general. So we said, is there a theoretical framework for continuing certification? What's our basis for doing this? And what can science of learning and motivation tell us about how to make that program a better one for physicians, much more beneficial than what we currently have? So we did commission an independent literature synthesis from cognitive psychologists at the University of Pittsburgh. They have a very strong program there at University of Pittsburgh, which deals with memory and cognition and just learning in general. And we got support from ourselves as well as Family Medicine and the American Board of Medical Specialties. And these folks provided us with a white paper, which is now on ABAM's website. You can find it under this citation, but it basically summarizes their work on the conceptual foundations for designing a continuous certification program for physicians. That paper is now being written up for peer review in the literature right now, and it's being published in a special issue of a cognitive psychology journal. So that should be coming out in the next few months. They keep telling us it's coming, it's coming, it's coming. And then we will be writing a overview for a medical journal so that it'll be a bit of more of a synopsis of what we found. But the methods of those researchers was really, their goal was to understand best practices gleaned from cognitive science meta-analysis of all this literature. They reviewed literature in psychological science and medicine, both theoretical and applied. There were 615 papers that came out of that, and they evaluated every one of them. You can read that in the white paper for their evidence level. Like, how good were they in terms of really supporting the finding that they came up with, and what kind of study was it? Was it itself a meta-analysis? Was it a narrative review? Was it a randomized control trial? Was it correlational? So you have sort of a sense of how strongly you want to believe those findings. And then they developed the white paper, a narrative literature review, and what we're calling our learning model with 4 basic themes in it. And from there, we got a set of practical recommendations for how we should go about putting together a continuous assessment program and what else needed to be studied, because not all our questions were answered during this process. Here's the model that they came up with, and I'll go through each of these in a little bit more detail, but certainly not as much detail as what's in the white paper, but give you some of the highlights. So the first theme was cognitive skills must be kept current. And this is sort of a, kind of a no-brainer. Cognitive skills must be kept current. You have to understand changing standards of care. As you age, you have to work a little bit harder to keep things current. And so we'll go into some of those elements to understand what they found a little bit better. We also found in there that self-assessment is not enough. So, again, the age-old question of why can't we just do continuing medical education? Why is that enough? And, there's a whole body of literature on why self-assessment in particular is not enough. And we'll go through that as well. The third theme was one that was, newer for a lot of our physicians that heard about this. And it's really coming from the assessment and learning industry, but that testing itself, the act of testing, enhances learning and retention. And we're not just talking about memorization, we're talking about clinical reasoning as well. And we'll talk about that in a few minutes. And finally, the last theme, and again, something that I think we all recognize, but we don't like to hear, is that goals and consequences do motivate us. When somebody tells me I have to present today, I will have my presentation ready for today. When there are no goals and no things motivating us, it's harder for us to achieve something. So we'll talk about how that impacts assessment in general. So let's talk about the first theme. Cognitive skills must be kept current. What we found, and again, I'm giving you the highlights of things that we thought were really interesting from the literature. And most of this is coming from memory cognition and the psychological literature, not so much from medicine. Knowledge is not always accessible. So in the absence of practice, skills do decline over time. So if you don't use something, you need to keep reusing it in order for it to be accessible to you fairly quickly. Knowledge must be retrieved fast enough to be useful. And some can argue, well, how fast? In internal medicine, it doesn't really have to be fast, but in surgery, it might have to be really fast. And so, that's arguable, but you still need to retrieve it fast enough for it to be useful. For myself, in measurement, if I don't really have a sense of what a standard deviation is or a regression analysis, and I have to go look those up in order to answer a more sophisticated question, it'll take me forever to get that answer. So you really need to retrieve this information fast enough to be useful. The other interesting finding we found in this area was that interference may occur from similar information. So you might learn something and learn it really well, and that old knowledge makes learning new knowledge or competing knowledge, something that's actually contrary, harder for you to accept. And vice versa. Once you get the new knowledge, then you forget when the old knowledge might have been useful, or maybe there's still times when it is useful, and that's harder to retrieve. So that interference in both directions is really important to remember. And finally, something that you're probably familiar with is premature closure. When physicians rely too heavily on experience, when a patient presents to you and you see a history that's very familiar, there might be one little thing that's different, and you rely on that a little bit too much, that could lead to errors and a wrong diagnosis or a wrong treatment. So we have to be careful about, taking a step back and thinking about our knowledge itself. Am I checking myself? Am I understanding where I could go wrong? So that just gives you a little bit of an overview of this area. Self-assessment, the second theme is self-assessment is not enough. And here, we found that learners do have some ability to self-assess strengths and weaknesses, and it really depends on the learner. But there are systematic biases that exist in self-assessment today. People tend to overestimate how much they will remember. I mean, just simple things like, where did I put my keys? You think you're going to remember where you did it, but you don't remember it. People stop studying too early. Again, not everybody. There are people that study too much. But in general, we stop studying too early, primarily because we overestimate how much we're going to remember. And then a really important concept is that poor performers are unaware of the fact that they are poor performers. So even though you might self-assess yourself, you get something wrong, you think you now have corrected it, you don't always know that you're a poor performer in that instance. And what we like to talk about, and this is near and dear to Furman's heart, is the Dunning-Kruger effect. Kruger and Dunning came up with this article many, many years ago, talking about the unskilled and unaware, how difficulties in recognizing one's own incompetence led to inflated self-assessments. So if you're not really truly aware of what you don't know, you could think you're doing better than you are. And here's a chapter, here's the contents of a volume that David Dunning produced in Advances in Experimental Social Psychology. And you see basically a lot about ignorance and what ignorance does to you in terms of the learning effect and the lack of recognition of it. So we all have our blind spots, and we all, don't know what we don't know. And this is really just honing in on that. Being ignorant of one's own ignorance is important. And this is sort of the bottom line to the Dunning-Kruger effect. On the x-axis, you'll see here that this is objective performance. So these are the bottom performers, and these are the top performers. So people who did poorly on an exam and people who did really well. And what you'll see is, their actual performance. So the bottom group is down here, and then they go all the way up to here. And these black lines basically say, if you would ask people how they're going to perform overall on the ability, that's what the perceived mastery is, or on their performance on a particular exam, what you find is the people that actually do poorest on the exam think they're going to perform pretty well. And the people that do the best on the exam actually underestimate their performance just a little bit. And you can see that pretty much everybody is overestimating their performance until you get to that top group. So really an important concept for us to understand that, we're not always good at estimating what we don't know. So the third theme kind of ties into that, in terms of, so what do we do about that? What do we do about if you don't know what you don't know? And that's where testing comes in and can be useful. I know we don't all like testing, but it does help us certainly with learning and retention. And there is an effect called the testing effect. The testing effect means that you can actually test somebody over and over again on a specific concept. And just by the act of testing and getting feedback from that testing, they do better. Even better than if you said to them, go study for 10 hours on this concept. Go open your book, go through the material again, and retest. They found that the testing experience itself helps with learning, even more so than just learning through the traditional way of learning. And why is that? Well, testing itself constitutes retrieval practice. You're going over and over again, and you're developing strategies for retrieval. And like I said before, it's not just about memorization. People think, well, of course, it's going to help you remember a sequence of events or something, where you're going to have an acronym to remember it. But it's not just about memory. It's about clinical reasoning and how you synthesize information. It also helps you increase distinctiveness of individual study episodes. So if things are very similar to each other, and you get questions that actually tell you how distinct they are. So like maybe you'll get a question on pulmonary disease in one instance and a question on cardiology in another instance, or heart disease in that instance. And they're kind of similar. The presentations of the symptoms might be similar, but then when you actually see the two questions and look at them side by side, you actually understand where they're distinct and you could better understand how to apply the material. The other thing that helps us with learning and retention is what we call spaced repetition. And that's doing this testing over time in spaced intervals. One of the things that we did not learn from the literature was how often do you have to do it? Is very frequently really good? Is every 2 months better? What content requires more repetition than others? And that's something that hasn't been studied really well, or at least we didn't find it in the literature review. So that's something that we'd love to study over time. The other thing we found at the very beginning when we started our longitudinal program, people came to us and said, well, can't we have, this year of the program for internal medicine should be about rheumatology, and next year should be about cardiology, and then the third year should be about nephrology. Well, what we found in this literature is that actually interleaving the categories together is better than presenting them one at a time, so that you actually get the connections between the two. It doesn't help with being able to study them separately, but it certainly helps you with understanding them better. And importantly, giving feedback with the correct answer is really, really important. So not leaving people open-ended like we do with our long form exam, where you really don't know the answer after you take the 10-year test. But with our longitudinal program, you actually will get feedback with the correct answer. You understand what the rationale is, and you get references to read more about it. So all of that helps you with learning and retention. And finally, the last theme is one, that's a little bit different than the others in the sense that goals and consequences motivate. So the expectancy of being tested leads to better learning practices and better retention. There's a lot of literature on this. Some of it comes from economics, some of it comes from, a little bit different fields, but the fact that you're getting tested does lead you to learn better and retain better, and it motivates you. But there's a caveat there. As long as the test is not perceived as too easy or too difficult. So I have too difficult on this, but also too easy. If it's going to be so easy, you're not going to be motivated to do anything. If it's going to be so difficult that you'll never succeed at it, you also are going to have problems being motivated. And to get at that level of difficulty, sample items with feedback may help physicians set expectations of that test difficulty. So what kinds of assessment are most motivating? Well, we have found that those are ones that have high perceived benefits, that they appeal to physicians' intrinsic motivation to keep current and provide good patient care. So those that they see are reasonable, that are relevant to their practice, so that they feel like it is covering largely what we do, what a physician does in practice. Those are going to be ones that are motivating to physicians. Also, those that have low perceived costs. So if you're not going to have to spend an enormous amount of time and effort to prepare for that assessment, people are motivated more by taking those assessments. So, we think that move towards the longitudinal assessment may help with this issue of feeling like you have to cram everything in 3 or 4 months before the 10-year exam in order to feel prepared for it. In the longitudinal assessment, you're allowed to make mistakes in the first year and not feel too bad about it because they don't count as much as in the following years. So you can improve your learning over time and concentrate on the things that you don't know, rather than having to cram all at once. And the final concept I wanted to sort of introduce here with motivation is test anxiety. And I think you all probably have experienced really high test anxiety at times. And what we have found is that anxiety about doing poorly on a test reduces performance, as does no anxiety. You might have heard about the upside down U-shaped curve, which is basically low levels of anxiety and very extreme levels of anxiety reduce your performance. You just don't do well at those extremes. Middle level of anxiety, though, is good for performance. So some level of anxiety is good because it does motivate you. Lower stakes retrieval practice, like we're doing with the longitudinal assessment, does help alleviate test anxiety during the process. You also get used to the item format. You have time to do it. You're not pushed as much in terms of the timing of the test, and you were able to get used to it over time. So this is just a quick, again, recap of the model. We found these 4 things, themes that were really important to us, that we wanted to delve more into. We didn't learn everything we wanted to learn from it, but we learned a lot from these 4 themes, and we have a lot more work to do in our longitudinal program to understand more about it. So in conclusion, just testing can potentiate learning and retention. We have the testing effect, retrieval, practice, spaced repetition, and feedback are all essential for learning and retention. And that goals and consequence do motivate learning. If you have some expectancy of a high stakes decision, that's going to motivate you, and making the test as intrinsically motivated and as relevant to a practice is very helpful as well. Giving appropriate levels of anxiety and not having to spend gobs of time studying for something will actually help with the learning and retention and the motivation. Okay. So I'm going to stop there. I don't know if you want to take questions now or let Furman finish, and we can take questions at the end. I think these 2 kind of tie well together, but it's up to you how you want to do this.
Yeah, we should move on to let Furman go,
Okay.
and then
Thanks.
people can start putting in the chat, and we'll have questions afterwards.
Okay. Thanks.
All right. Well, then I'll pick it up from here. Thank you, Rebecca. Thank you, Dr. Lipner. I just want to thank the organizers of this talk, Roswell, Dr. Ginsberg, in particular, because you're giving me the opportunity for the first time in my career to present with Dr. Rebecca Lipner. I have admired her work even before I came to ABIM, and now I presented a lot of her studies, which I'm going to do in a minute, but this is the first time I've got to present with her. So let's go to the next slide. What I want to provide you today is just really a whirlwind tour of a subset of the studies that are around the hypothesis that doctors who are able to demonstrate medical knowledge and more medical knowledge as a group are associated with better patient care outcomes than doctors who are not able to demonstrate that. Now, it's going to be provided in the context of certification MOC, because that's a lot of where the work has been done, but it's not, that hypothesis is, I think, holds true even outside of certification in MOC. But it does tie back to the ABIM mission. Remember, the ABIM mission is to certify internists and subspecialists who demonstrate the knowledge, skills, and attitudes essential for excellent patient care. And I have often held that the most important verb in that mission statement is not certify, but demonstrate. And so this next part is about that demonstration of knowledge, and may be relevant to your curriculum considerations that you're pursuing. So just a caveat, I'm not going to spend a lot of time on method on any one of these studies. Any one of these could actually fill an entire talk. So this is sort of a series of bottom line outcomes to help make that point around the central hypothesis. So next slide. So I'm going to start with mortality, because everybody seems to want to start with mortality. And actually, John Norsini, who was at the board and then was the president of the Foundation for the Advancement of International Medical Education Research, FAMER, part of ECFMG, he did this study back in 2000, looking at data from the 1990s in Pennsylvania, and actually demonstrated a 15% reduction in mortality if a doctor were cared for by a certified physician versus a non-certified physician in acute myocardial infarction. There was actually an added benefit if that certification was in cardiology versus primary care. Now, Dr. Roswell, it'd be surprising to think of someone being cared for with acute myocardial infarction in today's age not being cared for by a cardiologist, but there was a time. And in fact, these are some of the data that support that benefit. Next slide. John Norsini, and I actually had the pleasure, Rebecca and I, getting to work with his team on this study, just published this last year, actually went on to really assess that first question about certification, and then also assess doctors who maintained their certification, participated and demonstrated their passing the MOC exam, and actually found that, again, that decreased mortality in an order of magnitude similar to what one sees in the use of aspirin for MI. Now, we're not making the claim that certification and MOC are causing that, but I would say that there is probably a plausibility hypothesis that doctors who are staying current in medical knowledge may be actually more likely to apply the evidence-based practices that go along with good patient care. Next slide. Another study, third study that I know of, or there's at least 4 or 5, but this is the third one, showed a mortality benefit in physicians in hospital outcomes for percutaneous coronary interventions if one were certified in interventional cardiology versus not certified. Next slide. Now, the RAND study in 2010 was one of the first to look at a large array of quality measures. They looked at 124 different quality measures from over 1 million patients treated by over 10,000 physicians. They were looking at whether the doctors were board certified or not. And on a host of all their measures, they actually found a benefit for board certification versus not. Now, this is just a binary outcome. So hold that in mind, because that's going to be important as we move forward. Next slide. Brad Gray, who's done a lot of really great work, had looked at HEDIS measures, so again, process of care measures, and actually looked at maintaining certification versus not maintaining. So the RAND study was certified or not. This is MOC or not, and again found a positive benefit for, or association. Let me be careful, a positive association for those who were maintaining certification versus not. Next slide. And that from that, ABIM's infographics, research infographics, if you scale those measures out, you can estimate the number, for instance, of women who get appropriate mammogram screenings if doctors are maintaining certification, or appropriate diabetes care or coronary artery disease care. Next slide. But where it really gets interesting to me from an education research standpoint is when we begin to see what I call a dose effect, medical knowledge dose effect. So Eric Hombo, when he was at the board, the first study that I know about demonstrating dose effect is this one, where he looked again at some process measures for diabetes and mammography care, or mammography, and looked at how likely were these process measures to be met if doctors were in the bottom quartile, middle quartile, or top quartile of performance on the MOC exam, not just pass or fail, but performance. And we saw a linear increase with the higher scores. The higher the scores, the more likely people were to have the appropriate process measure. Next slide. And so now a series of these studies have now been done, or several studies have now been done that are showing similar findings. So here's a finding again from Brad Gray in 2021. Over 10,000 general internists, over 55,000 low back pain visits. And what it was kind of a very interesting study. So he looked at a time period before and after opioid prescribing guidelines had changed. So, right. So before the guidelines changed, there wasn't much difference in the prescription of these opioids for back pain. But after the guidelines came out, particularly focusing on not prescribing opioids for this type of acute back pain, those in the higher score group, the top quartile of performance, were less likely to have what would be potentially inappropriate prescriptions, suggesting that those who are staying current in medical knowledge may actually be applying it at the bedside. Next slide. And then Jonathan Vandergrift, again, I think with Brad Gray, looked at the dose, looked at potentially inappropriate medications in the elderly. This is a host of different medications. You can see any medication, anticholinergics, pain medicines, et cetera, and found, again, this dose response. So in almost every category, lower scores are on the left, by the way, higher scores on the right. So for each one of these, you're seeing a dose response, most prominent there in the anticholinergics in the middle, that those who scored higher on the MOC exam were less likely to prescribe potentially inappropriate medications to the elderly. Next slide. This study, though, is actually one of the, I think, one of the most clever studies that I've seen done, and actually shows dose response across multiple outcomes. So Brad Gray, just real quick on method, they looked at actually the diagnostic subset of questions on the MOC exam and performance on them, then looked at Medicare data for diagnoses that are prone to diagnostic error. It's really hard to study diagnostic error, because how do you study how do you determine if something wasn't done? But what's interesting in this study, so let me just give you an example. Take headache. So someone presents to the primary care doctor for headache. There are potentially history, physical, other findings that the internist would determine that might raise red flags for a headache that could be a cause of something worse than a less concerning benign headache, for instance, an impending stroke. And they looked at a series of different diagnoses of this kind of category, prone to potential error, and looked at the outcomes for doctors who are in the top, middle, or bottom tertile of performance on the MOC exam on the diagnostic questions, and stunningly found that those that were performing the top tertile had nearly a 3% absolute lower mortality, 30% relative, but from 8.1 to 5.2% mortality. And then you see the similar dose response for ED visits and hospitalizations. So this again is supportive of the hypothesis that doctors who are able to demonstrate that they know more are associated with better outcomes. Next slide. And then the question is sometimes raised, well, what if you just had really great systems? Could the systems compensate for medical knowledge? And bottom line is no. Next slide. This slide takes a little bit of description. So on the vertical axis is increasing measured quality. So, and this was actually from abstracted charts for the physicians involved in the studies, of which there were again, many, and increasing score for each subsection along the bottom. But the blocks that you see separated by the vertical lines, these are from going from low to high practice infrastructure. And practice infrastructure was measured with an NCQA validated tool for whether the practice was high practice infrastructure or low practice infrastructure. Go all the way to the right, to the high practice infrastructure group, because there the effect is most prominent. And what you can see is from low to high performance on the exam, quality increases as knowledge increases. But now go all the way over to the left for the low practice infrastructure, and basically nothing hits statistical significance. Still, the highest performing group does have the best quality, but we can't tell you that that's statistically significant. So what you can glean from this is you can have a system so bad that even the best doctors are not able to, can hinder their quality. But even in high practice infrastructure systems, doctors who know more are associated with better quality of care outcomes than doctors who know less. So you can't compensate for lack of medical knowledge just by practice infrastructure. You can hinder quality by low practice infrastructure, but you're not going to compensate for medical knowledge. In fact, that highest group, they start having significant outcomes even at the modest practice infrastructure areas, not at the lowest, but at the modest one. So this is actually I encourage you, if you looked at any two studies in this series, three studies, I'm going to tell you the two. One would be the diagnostic error study, and then this one I think is very clever. Next slide. But I want to spend a little bit more time on disciplinary action because state medical board disciplinary actions has been looked at both in initial certification and MOC, contains a lot of important information around this hypothesis about demonstrated medical knowledge. And then what I'm going to show you for internal medicine has actually been repeated now across multiple different ABMS boards and across other measures of medical knowledge, including licensing exams. Next slide. So I'm going to start actually with one of Rebecca's studies. Dr. Lipner, this is your study, but I'll go ahead and talk about it. So this study was done, and she can correct me if I get it wrong at the end, but this study was done in part because there had been some criticism that, maybe the certification at the end of GME was keeping internists out of the pipeline. Turns out it's not the case. About 95% of people who start internal medicine residency will finish it and become certified. And that's that box on the left, the ABIM group. But that group, if they finish residency and become certified, have a very low rate of state medical board disciplinary actions in the time period after residency. It's about 1.4% or so that actually go on to not finish internal medicine residency, but transfer into something else and become certified for another ABMS board. That's the middle group, and they have a little bit higher rate of disciplinary actions. But 3.4%, and again, this is on 66,000 physicians, so this is a large number of doctors, don't finish residency and don't become certified. They do become licensed and they go on to practice, and they have high rates of state medical board disciplinary actions, about 5 times higher than the 1.2% over there for ABIM. Next slide. And the severity of those actions turned out to be greater in the group that are not certified. Next slide. So that was interest. That was a study in the 90s. But one of the first studies was on certification with Maxime Papadakis in 2008. Now, Maxime Papadakis had published a study earlier to this one in the New England Journal looking at professionalism in medical school and professionalism ratings in medical school and subsequent disciplinary actions. And that got published in the New England Journal. They went on then, working with Rebecca and others at the board, to look at GME. And they were primarily looking at professionalism outcomes, but they also looked at score on the exam and controlled for the professionalism rating of the program director. Now, as someone who has medical education research, I often say med ed research is really medical education epidemiology, because it's really hard to do randomized controlled trials in med ed research. And people also talk about, like, where were you when? People know where they were when some big events happened in the world. I remember exactly where I was when I first saw this graph. And I opened the Annals of Internal Medicine in my program director office at Mayo Clinic, and I saw this dose response. So on the vertical axis are actually numbers of disciplinary actions. On the horizontal axis, from lower on the left to higher on the right, are scores. So higher scores to the right, lower scores to the left. And these are Z-scores. You can think about standard deviations. It's not exactly standard deviation, I know, but it's in that range. What you can see is this is about as a perfect linear dose response as you'll find. And doctors who are able to demonstrate that they know more are having lower rates of state medical board disciplinary actions than those who are not able to demonstrate that. And this actually called into question the professionalism hypothesis for disciplinary action, in part because they were controlling for professionalism ratings, but also in part because it's really hard to argue that someone who scores 2 standard deviations above the mean on this exam is more professional than somebody who scores 1 standard deviation above the mean, right? I don't question their professionalism, actually, but I do question their level of medical knowledge. Next slide. We went on to study this then in MOC to repeat this study, and we found, similar to certification, that those who passed the MOC exam had lower rates of state medical board disciplinary actions than those who did not. Next slide. Again, we saw this gradient in severity. They were less, those actions were more likely to be less severe if someone had passed the MOC exam. Next slide. And we saw, again, this almost perfect dose response, so that doctors who demonstrated higher scores were less likely to have disciplinary actions than those who scored less well. Next slide. But this graph really, I think, gives a lot of insight into the difference between performance and participation. And here's why. So let me walk through this. So on the vertical axis, again, we have percentage of disciplinary actions. On the horizontal axis are years after initial certification. The blue triangles there are those who passed the MOC exam within 10 years. So they came to their 10-year mark, they took and passed the exam, demonstrated the medical knowledge. Now, I call this sort of the floor of professionalism. It didn't eliminate all, there is not, it's not like nobody here gets a disciplinary action, but this is the lowest level. The red squares are those who took the exam but failed it. Okay, so they participated in the MOC program. They did everything they needed to do to be able to take the exam, but they weren't able to demonstrate the medical knowledge. The green X's are those who did not take the exam within 10 years. So let that sink in for a minute. Those who took and failed the exam had the same rate of disciplinary action as those who never participated, who never took it. We went on to break this down even further, but that's the central point. It's actually the demonstration of medical knowledge. It's taking and passing the exam, not just participating, that was associated with the lower rate of disciplinary action. Next slide. So what about the magnitude? So I remember Maxine Papadakis' study in the New England Journal on professionalism in med school and subsequent disciplinary actions. That had a population attributable risk of 25%, got published in the New England Journal. The population attributable risk to disciplinary action with MOC is 35%. In fact, it was the strongest indicator for subsequent state medical board disciplinary action study. Next slide. And go ahead and click again. This actually potentially puts a lot of patients at risk. In our study, there were about 1,000 patients, physicians who were disciplined. The literature at the time showed general internal medicine panel sizes between 1,000 and 3,000 patients. So that could potentially be close to 1 million to 3 million patients exposed based on just the numbers in our study. Next slide. And just to say that state medical board disciplinary actions, I guess I took that slide out. I have a slide with an iceberg. Disciplinary actions are a tip of the iceberg phenomenon, right? So you have to actually rise to a certain level of before something will actually trigger a state medical board disciplinary action. So in our MOC study, we demonstrated that someone was more likely to be disciplined if they did not pass the internal medicine MOC exam. That was the strongest indicator. If they had failed the internal medicine exam, and that was similar to what had been shown before. If they were male, older, and from the South, I here need to disclose that I'm a man over 50 from North Carolina. And if they came from states with higher disciplinary action rates, which makes sense. One thing I'm not showing the data on, but we found no difference in CME requirements. And we were able to look at this because turns out there's a wide variation of actual CME requirements for licensure. I'm licensed in 2 states. I'm licensed in the great state of Minnesota and the Commonwealth of Pennsylvania. And in Minnesota, I have to have the equivalent of 25 CME credits per year over 3 years. And in Pennsylvania, I have to have 25 per year over 2 years, plus some extra training in opioid prescribing and in child abuse recognition and a few other things. At the time this study was done, there were 5 states in our great union who had no CME requirements to maintain licensure. So it goes from 0 to up to 100, 120 over 2 years. And we found absolutely no difference in how much was required by the state and state medical board disciplinary action. Let me caveat again to say that's not the same as saying CME doesn't work. It's saying the thresholds of CME requirements for the states at that time were not associated with disciplinary action. Next slide. So to wrap up this whirlwind tour around medical knowledge and before we get there, medical knowledge, it was not just professionalism. A lot of people for disciplinary action have had the, I think, misunderstanding that disciplinary actions are related only to professionalism. Our data didn't support that, in part because it was passing, not just taking the test that mattered. That supports medical knowledge. The dose response strongly supports medical knowledge. We didn't show you this, but the disciplinary action rates were associated with medical knowledge were independent of baseline professionalism, which we did have ratings of. And I think importantly, at least 2 studies now have out of FSMB have shown rated the causes of discipline for state medical board disciplinary actions. And the number 1 single cause of discipline is something called negligence or incompetence. It accounts for about 1/3 of all disciplinary actions. Now you can add up all the other causes of discipline, and that's 2/3, and those might be professionalism. But about 1/3 of disciplinary actions relate to actually what would be very consistent with medical knowledge. So did someone miss the diagnosis? Did they not think to order the test? Did they misinterpret the test? Those sorts of things. And so there's a plausibility to why medical knowledge could be associated with fewer disciplinary actions. Next slide. So in conclusion, now I'll conclude on medical knowledge and its association with patient relevant outcomes. We've shown you a few studies that medical knowledge is associated with increased compliance with guidelines, multiple studies showing that, and better outcomes, including reduced mortality. We didn't show you the cost study. If people are interested, we can talk about that. Better performance measures and fewer disciplinary actions. Next slide. And that's all I have, except for questions. So let me pause here. First, the first thing I would ask is, Rebecca, did I mess any of that up, especially on the studies that you authored? But then I would open it up, Dr. Roswell, back to you and others on questions.
No, you were good, Furman.
Yeah, I thought that was
Thank you.
That was great. And I see we can take down the slides, and there's a couple of questions are coming in the chat. And I saw a hand. I don't know, Brian, I saw your hand go up, but maybe Furman, could you talk a little bit about the other 2/3 of the disciplinary action in terms of what sort of things are in there besides the incompetence or negligence? What else is in that bucket? Do you have that information?
Sure. So I don't have them all off the top of my head, but in general, those would be the kind of professionalism actions you might anticipate. So for instance, boundary issues, fraud, the kind of illegal activities or activities that one would more commonly associate with acts of professionalism.
There would also probably be some diagnostic error issues in there as well.
Well, that would probably fall more in that first category, though, Rebecca, on negligence and incompetence than medical negligence. Yeah.
And I know there's another one in the chat, and I see David has his hand up. Brian, did you have your hand up as well? No. Okay, I saw someone's hand go up and drop down. So maybe David, you could go ahead, and then we'll take Ethan's question in the chat next.
Yeah, thanks. Thanks, guys, Furman. And it was certainly a lot of things you say, certainly resonate, make a lot of sense. Certainly the part about testing and part about people not being great self-assessors, et cetera. And we've heard, previously about some of the information about those who don't do well either on MOC or continuous testing over their careers, not providing the best care. I guess one of the things that we're trying to think about at the school level is how do you provide the environment and the type of experience to get people to be lifelong learners? Because my confirmation bias on this is those are people who fall off the curve, that they stop trying. And I, as my group knows, I think I even see some of those people in medical school who just don't seem to love it and don't embrace it, don't figure out how to keep learning, how to stay active, fall prey to what you talk about in terms of their own ability to self-assess, overly confident, arrogant. I won't even go into the professionalism side, and obviously patients suffer. So how do we avoid that?
So they should enroll in MOC first of all. I don't know that I have the solution. I'm not a physician, so I don't know how to intrinsically motivate them. But I do think that, what we have found with what I have experienced with the difference between our longitudinal program and our 10-year program, where, you just study on your own, and it's much more directive. And you are giving people the tools, at least, that they need. Whether they use them or not is a different story, but the tools that they need to sort of know which areas they got wrong, what was the question they got wrong, why did they get wrong, read more about it. Now, whether they'll go do all the things that they need to do to improve is questionable. I think we're currently working on trying to work with societies to help us give remedial programs to folks who need it. So maybe having those things much more accessible will be helpful. But again, if somebody's not really willing to put the effort in, it just may never happen.
So if I might, first of all, Dr. Battinelli, wow. So great to see you. I think I haven't seen you since the Aptum stage many years ago. I don't pretend to have the perfect answer to your question. I do have a hope, and we are hoping to take some of the work around data like you saw here tonight at the transition from GME to practicing physician, or in our world, from certification to MOC. And actually have done some, I think I've interviewed now 50, 60 different program directors around the idea, could we find ways to inculcate this idea earlier, that if we can get the resident to believe that, in fact, they're going to need to keep up over time, that if they can build that now into their routine, that it does have potential for better outcomes, right? So that it isn't just another hoop to jump through, that it's a matter, it's not the test that's important, it's the staying current that's important, right? So, and the test is a demonstration of staying current over time. And we are finding different ways to demonstrate that. The longitudinal knowledge assessment is demonstrating that, we think. And but I think not being able to demonstrate it is the real risk. And if we can show people that they need to be able to assess themselves against a known standard rather than against just looking in the mirror, we might have some hope to make that.
Thanks.
Great conversation. Keep the questions coming in the chat. I know you talked about the data in terms of scoring and professionalism and all of those other things. And I know there's no causality, right? And so it's just an association with higher scores and this professionalism. Can you talk a little bit more about what that link might be? And this is something that Ethan Frieda was asking about. Like, what's responsible for that? Is it just that you feel more confident because you know the knowledge that you don't do things, or what did you find out when you did that study? What intersecting thoughts or sentiments drive the unprofessionalism when you get lower scores?
So I want to be
or
very
associated
careful.
with.
I want to be very careful. I actually don't think it's unprofessionalism. Right. So we should not equate state medical board disciplinary action with lack of professionalism. That's my key point here. It's that actually medical knowledge is associated with things like diagnostic errors and, not interpreting the guidelines appropriately. That it's actually that the medical knowledge is a key component to that part of it. And as far as causality goes, and I mentioned epidemiologic education research being educational epidemiology. There are some tenets of causality, right, in epidemiology, one of which is gradient and dose response. And when I saw the dose response in state medical board disciplinary actions, it really triggered a oh my goodness, this is the closest thing I've ever seen in education research to something that could approach that. It does have plausibility. Doctors who know more may very likely provide more evidence-based care or be more likely to get the diagnosis correct and not miss the diagnosis. So I actually think for the, don't misunderstand me, I'm not saying certification MOC, but for medical knowledge being associated with better care, I actually think we're beginning to approach meeting the epidemiologic tenets of causality. That is a controversial statement, but I do think there's at least an investigative pathway to be approached there.
I think there's another interesting question in the chat, and just keep them coming, in terms of quality of care and scores with those who have learning difficulties, like sort of accommodations for taking, step 1, step 2, step 3, but there's also, there must be accommodations for sitting for ABM assessments, and how that factors into all of the outcomes. I don't know if you've done those studies, but I think, Barbara, that was a great question.
Yeah, we actually haven't, we don't have enough people with disabilities to do the study, but they are in the study. So when they get their accommodations, we're assuming that those accommodations were sufficient enough for them to demonstrate their knowledge, expertise. And so they are part of the study, and so the findings sort of include them, but we don't have enough of them to sort of pull it out and really study it separately.
And another one in the chat, I think, over the years and decades, have you found an effective way to deal with the people who don't know what they don't know, in terms of FOC and how that happens? Is there an answer to that one?
So we're trying to study that right now. So we have, in our longitudinal program, we have questions that we ask after each exam questions, sort of how confident are you in this answer? And how important was it to your practice? How frequently do you see that? And putting that information together, in a format that the learner can understand and say, hey, I was really confident in this, but yet I got it wrong. We're hoping will make an impact, although I don't know that it will. Some people, you will say, oh, that was just a fluke, or, it depends on their arrogance level and whether they want to believe it in themselves. But we're giving them, again, the tools that they can see, okay, you said you were confident, but you got it wrong. You really need to pay attention to those particular questions, because you have a mismatch there.
So along that line, Rebecca's got the current on what's going on at ABM. I will say David Dunning has attempted to study this, and I would say some of his studies are quite they're all quite interesting. I won't say they're very encouraging. So the one that comes to mind in particular is where he looked and found the Dunning-Kruger effect. Again, people who were less did less well on objective measures perceived themselves to be better. It was actually on a test of emotional intelligence. And in follow-up, he offered to give them a book and pay them to take it, take the book and read the book. Anybody who was in part of the study. And there was a big uptake of the group of people taking the book, wanting to learn more, but it was in the group of high performers.
Right.
So the high performers would actually, want to try to learn and do more. And those who needed it the most did not actually pursue it. So, I'm hopeful we can find a better way than that.
Yeah, I think there's a lot of interesting questions coming down the pike here, and I think Dr. Brenner's question we'll try to answer next. Has the dose effect, do you know if that's been in step 2 CK or step 1? Do they also have those same outcomes related to the scores in 1, 2, and 3?
Now, if you're breaking down the steps, I think the only study I'm aware of, I think, is the one probably that you're referring to is the step 1 study, if I'm remembering right. And it was Rebecca was our
Yeah, there's only been, I think, that one study from USMLE, but there have been quite a number of studies from the other medical boards. So family medicine has done a study, surgery has done a study. They're all finding the same dose response. So we're happy to give you the complete list of all the studies in those areas, because it's pretty, it's compelling because of so many are repeating it with different kinds of exams all across the board.
And I think this dovetails on that nicely. So if you'll give us all the studies about the dose response, would you give patients the information about their physicians and their scores? And so I could imagine, and Bill Rennie was asking this, I could imagine if I'm a patient out there, kind of want to go to the doctor who has the highest scores because the outcomes seem to be better. And so why would I want to go to a lower tertile doctor? And I think this was a lot of discussion about this data and what people will ask. And so that's a great question. And I just would love to give you a chance to respond to that.
So I will, having been at ABM for a long time, I will say that that's been a conversation for you, Rob, at the board level of, whether we release scores or not, not necessarily the exact score, but quartiles, tertiles, something that would give more of a flavor of the span of performance. To date, the board has not wanted to do that. It was really about being certified and not being certified, and it didn't really matter where your score fell. So I think that has been a long-standing debate. Obviously, the difference in 2 or 3 points or even 10 points doesn't make a big difference. So you have to be a bit careful about which scores you release and how do you release them. But there has been a debate. In fact, years ago, Consumer Reports, when they were doing well, came to us and said, why don't you rank your physicians in some way so that we can, do a really good mock-up of, who's performing what out there. And the board really didn't want to go there for probably good reasons. The exam really wasn't set up for distinguishing at very specific score levels. It was really set up to distinguish between certified and not certified.
And I'll just say that, for years, residency programs have asked their applicants to provide the actual scores from their, USMLEs and steps and other things. There's nothing stopping employers or others asking for the ABIM score report. Frankly, if the candidate asks us to, we would provide it to them to give. But it just hasn't caught on. People haven't done it.
Yeah, I mean, we have had people, ask us to tell them what percentile they're in, so that they could give that to an employer and saying, I did better than 90% of the people, and that helps them get jobs. But we're not publicly displaying that.
And before we go on to Rona's question, which is a good one, I just wanted to ask a little bit more about that, about the outcomes, and how are they adjusted or looked at by race and ethnicity and gender. And so sometimes we see some disparities in terms of medical knowledge, but then cultural humility is lacking, and then that sort of intersects with health outcomes in that way. So I'm just wondering if that also was something that you were looking at in terms of medical knowledge and the intersection of race, ethnicity, and gender and culture, all those complicated things.
Well, I can say it hasn't been done now because, Rob, as you know, we haven't had data on actually race and ethnicity up until like the last 2 years. And for those that don't know, we, collaboration with AAMC, have been able to get some of those data. But Rebecca, I'm not sure what's in the pipeline for study.
No, I mean, that is something that, we certainly want to reproduce and see what's going on there. We have looked at gender in that setting, but pretty much not, we didn't have race and ethnicity when these studies were, we didn't have the data for race and ethnicity for physicians when these studies were done.
Interesting. And so let's get to Rona's question. Looking at USMLE, everyone's going to pass fail, and just saying that looking at your data, this seems to run contrary to that notion that USMLE should be pass fail. Just wanted to give you some room to comment on that, moving pass fail with these standardized tests.
As a former residency program director, I could have a very short answer, which would be, I agree with you. But just to say, I know that the whole USMLE pass-fail decision is a complicated one, in particular around, here's the diplomatic answer, in particular around the, what's the purpose of USMLE, step one, and it's actually a licensing exam. It isn't a residency entrance exam, and so I understand some of the arguments on both sides of that. As the program director in me, I mean, it was yet one more data point, and it unfortunately, I think in the GME world is now making step 2 CK become even that much more high stakes for students, but that's probably beyond the scope of my, certainly the scope of my oversight.
Hey, Rob, it's David. If I could jump in again one more time.
Go ahead.
I guess I'm sort of still confounded by the early days, right? So meaning, you're in med school, you're in residency, there's differences in people skill-wise, testing-wise. What I'm taking from this conversation is again, what really matters is keeping up throughout the rest of your career. And that's the real special sauce. How do you, to taunt Rona, how do you know which students to admit? Because to me, there's so many high scores, and I would be most interested in those students who want to continue to perform throughout their career.
Rona, you want to answer that one? Just joking. Brian, I'm going to ask you to ask your question now, but maybe I'll go to the ortho board first, and then you could ask your question next. In terms of they actually give their program directors the scores, part one of the ortho exam for their boards. Does ABIM do the same thing, sort of give programs back so you could have some feedback in terms of, at least for initial cert, so you could adjust your curriculum?
We do.
Yeah, go ahead.
Oh, I'm sorry, Rebecca. We do for initial cert. We do. So every program director gets the pass-fail result of everyone in their program, and if the candidate has agreed to release their score, which most of them do, not all of them, but most of them do, then we actually give back to the program director the full score report that the candidate got. And then we also do something else, which is a composite program score report, so they can see how their program is doing overall compared to other programs, and a breakdown of the high level blueprint nodes. So for instance, if my program is doing well in cardiology but not so well in nephrology, I can see that relative to others, and that is intended to try to help the program directors give some guidance on where they may need to shore up the curriculum over time.
Great. And Brian, why don't you go ahead and ask your question about surgical outcomes?
Thank you, Dr. Roswell. Dr. Lipner and Dr. McDonald, I really enjoyed your interesting discussion. My question is, shouldn't medical boards, I guess, be doing something a little more actively than what we're doing? What makes surgical outcomes or surgeons' outcomes and hospital scores, hospital care scores, what makes them different from this information? In other words, shouldn't we be supplying the public with this information if we really are doing our jobs?
Well, I would say about surgical outcomes, you may know better than I do if the board itself is providing surgical outcomes to the public. I know that that hospitals and health systems get a host of potential outcome data on their physicians. Hopefully they're using that for quality improvement, but ABIM doesn't get actual patient outcomes we are studying these from, Medicare data and large databases. Are
Right,
you
well,
asking about the scores themselves?
I was asking about the scores themselves, and I don't know what's going on in the other specialties. I'm a recovering surgeon for several years now, but doesn't it make sense that if we're being proactive and if we're being patient-centered and public-minded and warm-hearted, that we should, showing warm-heartedness, as they say in the East, that we should be maybe more actively doing this?
Well, it sounds like the question from earlier about
Bill's question.
Yeah, there was a question about should we be reporting on actual scores of physicians, not just pass fail of physicians, and it's been a debate for a long time. Certainly, institutions can ask for score reports, right? You can ask the individual physician for that. ABIM reports certified or not certified currently. And I'll throw it over to Dr. Roswell and the board of directors if they want to consider something different in time.
Yeah, we could bring that up when I roll off the board.
Right before, right.
Right before. That's a tough thing. And I would say, personally, I think it would create a lot more, I think, anxiety in the test taking. It sounds like it's going to be wrapped up with a lot of emotion, and there are those outcomes that we see, but who's on the cusp, and are you a better doctor than I am because you scored 2 points higher than I did? Do you deserve to get the job because I have, interest in taking care of these underserved communities and you're not doing that? And so it gets a little tricky. And so I think on the board, that probably would be our discussion. But I do think getting these data out, it's public knowledge, it's published in literature, so anyone could sort of pick up these journals and read that information. So it's out there. I just don't know how sort of active or aggressive we should do in terms of getting that message across. But I think these are all discussions to have. And
I
very
think,
important discussions.
Rob, I think your point is a good one. The articles are out there. I guess I'd like to hear from the audience, so of all the stuff that we presented, what would resonate with physicians to motivate themselves? In other words, if you knew that doing better actually will, in fact, have a correlation with good outcomes, would that be a motivator? And how could we package this in a way that is a little bit more understandable to, the average physician, and to patients, I guess? It's sort of like the evidence we feel is fairly compelling, and certainly about scores, and that could be an internal motivation, intrinsic motivation for the physician if they knew, it's not just about eking by, it's actually about doing better. So I'd love to hear, if you had any ideas or send us some ideas afterwards, because we've been struggling with that piece of it for a while.
Thank you.
Rob, can I just say one thing? Just really picking up off of what you just said, I think that really connects with what David was talking about earlier, right? Which is if you take the med students at the med student level and start educating them that better knowledge is going to give you better patient outcomes later on. Like, wow, what a powerful motivator, especially at a time when that is sort of like the pinnacle of people's, desires to serve patients, at this very critical juncture as they are, undergoing their professional transformation, and to build that into their fabric at that time, that might be something really to consider, along with other things. But I would say that it started as early as possible.
Yeah, I think that's a great point. I think as we start to wrap up, maybe we'll ask Dr. Lipner and McDonald to start thinking about the takeaways, what you think we should consider most strongly, while we put on in the link to sort of see what people took away from this particular talk in terms of the high level things. I don't see it in the chat yet, but we can put that in. There you go, and you could just fill in. So what are the biggest takeaways that you had from this particular talk? And what would you apply towards curriculum renewal?
Rob, are you asking us to?
No, we're gonna, the the people who are the participants of the call would sort of type in, and then as we get their responses, then we'll ask you and then we'll close out. That's right. And then before, and you can keep on typing in, and before Dr. Ginsburg wraps us up, I'll just turn to Dr. Lipner and Dr. McDonald to sort of say, out of all the things that you have talked about with us, what's maybe the strongest sort of point you would want us to consider while we're thinking about curriculum renewal. And I think these are really important principles that the participants are putting in.
You want to go first, Furman?
No, I'll defer to you, Rebecca, and then I'll go.
Okay. I really think it's about, that I really still believe that demonstrating how good you are is really important, and doing that over a lifetime is really what is going to make a big difference. If you're never asked to demonstrate it over your career, it lacks the motivation and the structure that is needed, but not just for yourself, but also for patients. And even if we're not putting out the scores, certainly with our longitudinal program, as you can see, somebody wrote, the growth of performance actually might be an incentive for people to do better. So as we start analyzing the data and giving you feedback on that, we'll be able to see how you're doing from year to year and whether you are growing or not and in which areas you are. So I think, the demonstrating performance through assessment, not really scary assessments, but assessments that help you learn, I think is still really important.
I should have gone first. She stole mine, but no, I would agree and say what we focused on medical knowledge. I think medical knowledge is extremely important. But as you renew your curriculum, which sounds really exciting in what you're doing, hold on to the importance of demonstration around whatever the competencies or the areas that you're seeking to train to. So demonstrate against a standard. Don't rely on self-assessment. Be very wary of self-assessment and actually demonstrate against a known standard. That would be my recommendation.
Absolutely. Competencies are where we're going, and that's really important. So I'll just invite Tamara, if you want to give any final thoughts towards what we talked about. I guess you could take down the Woo clap. These were great. Thanks all.
Yeah, thank you so much. Really, this has been, I think, a very provocative talk, and something that we're really thinking hard about and grappling with. And I think a lot of the information that you shared today will really help us as we kind of continue to formulate all of our thoughts in this area. So again, just really want to express appreciation to both of you, Dr. Lipner and Dr. McDonald and Dr. Roswell, for bringing us all together, to our events team and coordination group for making this possible. And of course, to everybody here for joining and participating in all of your thoughtful questions and discussion that we've had. So thank you. Just as a final closing thought, I want to let everybody know that our next speaker series will be on March 1st. And we have Dr. Cornelius James, who's an internist and pediatrician at the University of Michigan and is doing a tremendous amount of work around artificial intelligence. And the title of his talk will be "The Next Paradigm Shift in Medical Education, Preparing Clinicians to Use Artificial Intelligence in Clinical Decision Making." So I think that...
Can Furman and I join?
You are absolutely welcome to join. Please, we would love it if you would, in fact.
Okay.
We'll share that with you. So again, thanks again to everybody, and have a great night.
Thank you.
Thank you so much.